This is ASAP Pathway. Hi, friends. Welcome back to another episode of ASAP Pathway, the podcast. I'm your host today, Dr. Stacy, and my partner, Dr. Tracey, is with us today.
Hi.
I love when she can come on with me. I just think it makes the conversation so much more dynamic. And it's Thanksgiving weekend or week, the weekend prior to Thanksgiving, right?
Yep.
So I'm very thankful. I'm thankful for a lot of things in my life, but I'm thankful for our conversation today and our friends that we get to talk to today. I have interviewed them both privately, separately, I should say, in prior podcasts. So today we have Dr. Reza Movahed and Dr. Moshiri. Welcome.
Thank you so much for having us.
And if you guys want to check out the prior podcast, I interviewed Dr. Moshiri. I'm going to call him Maz today, episode 40. And then Dr. Movahed, Reza, is episode 44. I'm going to do like I said, an abbreviated introduction of them. And if you want more detail, go visit those podcasts because we've got to dive into some juicy stuff today. So Dr. Moshiri, he's been a faculty member for Align Technology since 2013. He's the co-founder of the Aligner Intensive Fellowship, an online residency that has educated nearly 5,000 orthodontists worldwide on the proper treatment planning and use of clear aligners. Currently, he is the clinical assistant professor in the orthodontic residency program at the Center for the Advanced Dental Education at St. Louis University, with a focus on clear aligners. Dr. Movahed is an oral and maxillofacial surgeon in private practice serving the greater St. Louis region, San Francisco Bay Area, and patients from across the country. I'd even say the world. I know people that fly in to see you. His private practice, Movahed OMS, concentrates in treating patients with dentofacial deformities and obstructive sleep apnea, requiring corrective jaw surgery, temporomandibular joint surgery, and combined orthognathic and TMJ surgery. And I am so lucky that I have these guys in my hometown. I mean, they're both here in St. Louis. Just so honored to have you both and work with you both. You're just very talented. You've got some great things coming. We've talked about winds of change in the past. The last 2 years have been amazing and growing and growing. And you're doing something different. So we definitely want to dive into that later with Winds of Change year 3. But I kind of wanted to jump in, Trace. I'm here speaking at an event. You're constantly speaking at events. And it just feels like there's so much information coming at like lightning speed, coming at everybody about the topics of orthodontics with, an emphasis of airway or an awareness of airway, oral surgery with an, airway in mind, being a primary care dentist, everyone getting on the same page. Dave McCarty says it all the time. The reason we're just not moving forward like we should be and where we're at is we're not speaking the same language and we're all operating in these silos, which is true. But I do feel like where we're at now, gosh, Reza, Maz, I mean, we've had so many lunches together and meetings over the years. Like, I would never imagine where we're at right now is where we would be. So we are moving forward,
Sure.
Oh, absolutely. I mean, it's the load of knowledge that's coming through our way. Options. It's
Yes.
hard to keep track of, and also the questions that arise in terms of sequencing and working with these options. It's getting more complicated by the day. We all figure out certain patterns of results and outcomes that we get in our practices, and we want to perfect it. And then, same thing happens in other specialties. Now we just have to figure out how we can combine that and sequence it in the best fashion possible, not to overwhelm the patients with options, number one, because it gets very confusing. You have the MARP, you have the FME, you have the MSE, you have this, that, which one's better, which one works better. What do you do before surgery? When do you use it? How much expansion is right? And I get involved in those conversations quite a bit as well. And frankly, I have to keep up with it as well.
Yes.
So it's becoming more complicated, but it is our job to do our best to direct our patient in a path that's going to be predictable. And that's the reason why when me and Dr. Moshiri work together, is really he's my sounding board, not just on the orthodontic portion of it, but when it comes to designing faces. We sometimes have different way of looking at the same face, but together there are things that I miss that Dr. Moshiri brings up, and I'm like, okay, it makes sense. Us putting our brains together makes that work. It is some beautiful things come out of it.
Well, you're right. I mean, having a team, and we had this discussion when we had, gosh, Trace, who were we talking to when we were talking about you have to have the end in mind? Was it Lena? We had Lena on.
Yeah.
You really have to, when you look at this patient, it's like, what's your diagnosis? What is your outcome? What is your end result outcome that you want? And then you have to reverse engineer it from there. And some people just go in guns a-blazing and they have a hammer, so everything's a nail, and they haven't thought about how to restore this patient properly. Or, so you have to have a team. You cannot do this by yourself. You cannot do this by yourself.
Yeah, I
Yeah.
see it almost like, when I talk to my patients, like, if you're building a house, everybody needs to be in the same plan. And I think what makes Winds of Change is going to be really unique is that we'll all learn how to speak the same language. And I think for patients, when they're looking for providers, their providers have to meet, and I think one, the providers need to speak the same language, the providers. I think for me as a restorative dentist, I don't do surgery, but I need to understand the surgery.
Yes.
So because what I have to do is I'm going to be the one holding my patient's hand when she goes through all this. And I'm the one that's going to be saying, I trust Reza in this. I trust Maz in this, and I think that trust with the whole group and the patient has more confidence in the trust. I think another thing too is that you have to have a team that knows how to call an audible. If you're only a one-track person and this is all that's in your wheelhouse, then I'd be also a little bit cautious about that because then you don't know when things go wrong and things will go wrong. But that's the beauty of that's going to happen in February. I mean, you guys put up an amazing lineup. I mean, where sleep physicians are coming together with oral surgeons, orthodontists, periodontists. I mean, you almost have every discipline covered in one weekend. I think it's going to be an amazing event.
Yeah, you don't see that very often. And
Yeah.
actually, I just thought of this because we are trying really hard to make sure that our audience is tracking. So for the listener, for the one listening, hopefully there's more than one, for the person listening right now. What is Winds of Change? How would you guys, I mean, we know what Winds of Change is, and you guys are going on year 3. What is
Yeah.
this? Why should somebody consider coming? Do you have to be involved? Can you be a novice? Do you have to be experienced to register? And what are they going to get out of this?
I'll chime in real quick. So one thing to kind of, I'm going to answer your question, Stacy, but I want to add to what Tracy was saying as well,
Yes.
is that in addition to, developing your team, a big part of your team when you're talking about airway is obviously having MDs involved. And this is a meeting that's unique in that there are MDs there. In dentistry, you tend to get so focused on dentistry itself. We go to an ADA meeting, AAO meeting, whatever the meeting is, and there's really actually physicians there. And so there's no multidisciplinary discourse. And it's sometimes daunting for whatever reason for dentists to speak to physicians and to guide them along a pathway of what they're seeing diagnostically, because we're not considered doctors per se. It comes to MD, but clearly, obviously, we've all gone through our journey of getting the acumen and becoming specialists or experts in what we do. And rarely do physicians actually see through our lens. So you can't diagnose what you don't see. And so by going through and trying to go through that journey together, we can articulate things, and this helps that. I think that helps that communication for dentists that want the most common frustration I hear. I give a lot of lunch and learns and lectures, and we talk about airway, is that I don't have an ENT on board, or I don't have an ENT that sees what I'm seeing, or I keep sending out and they don't actually do anything. So being able to articulate that and hear it from an actual MD's perspective so they can go have an educated conversation, I think is a huge, huge step for a lot of these patients and doctors, excuse me, that want to go on that journey. Now, as it pertains to winds of change, um, I think you don't have to have attended by any means any of the previous meetings. I think you come to this meeting, we keep trying to recreate the journey, but just do it better and better every year. And so we still have some of the same players involved in terms of like physical therapists or oral myofunctional therapists, orthodontists, periodontists, oral surgeons, sleep physicians, and so forth, general dentists, obviously. But our goal is to take the message, but continue to evolve it and recreate it so that if you came to any meeting, you would just be blown away. First of all, not only by the information and hopefully being able to understand the topic of sleep dentistry or sleep medicine as it relates to your patient, but then the pathway with which to then direct that patient down, be it a child or be it an adult. The journey is comprehensive and it covers all those spectrums. And so it's truly the most comprehensive, I believe, meeting involving this topic and the most multidisciplinary meeting regarding this topic. And then Reza recently, I think, evolved this to also have a hands-on component. So I'll let him kind of discuss that because I think that makes this truly unique as well.
Yeah, and it was so interesting, Maz, that me and you have evolved also as specialists, clinicians. We've been involved in restorative more than we have ever had before. We've been involved the peri portion with SFOT so much more. We see the value of it because, and I got to tell you one thing that I feel like I'm guilty of, and Maz always paid attention.
What does SFOT stand for, Reza?
Oh,
Well,
surgically
yeah.
facilitated. Thank you. Surgically facilitated
All
orthodontic
right.
therapy. Here we go. We're getting this down. We've been working quite a bit with Dr. Mandelaris, and be frank with you, there are cases that are 4 or 5 years down the road, and we follow our patients very closely. The ones that make it in, what we always would love to follow our patients, and we do. But the cases that are, for example, had somewhat of an overexpansion. Maz is always careful with that, by the way, but it had that overexpansion. It didn't have the soft tissue for that. We see the ravages of that because at the end, you have soft tissue that's receding. The longevity of teeth are not there. We did not pay attention to the restorative part from the beginning, which really should be, again, the end in mind. I'm guilty of that as myself. So we've been working with Dr. Vinci quite a bit in some of those cases and other practitioners. So we want to bring what we've learned that we've been missing to the table. But also, Dr. Rouse just recently contacted us, and he's going to be at the meeting. And he mentioned a part that I'm really interested in is to go to the cadaver lab and see. And he said, it makes me a better clinician. He's a prosthodontist, but he said, it makes me a better clinician to see what you guys are doing. Okay. And that really kind of, struck a chord with me because I hope that other folks would think that way. And find value in that because, you have to see how the mechanics of what the surgery would be what are the options. And we really, in a way, I look at this meeting as, hey, I'm going to, let's just say, Lollapalooza or Woodstock of the bands that I love. And all of them are playing,
Yeah.
and it's going to be almost, and initially we had two track, for the first day, which we made it all one track so everybody can hear all these amazing speakers, which a lot of them are friends that we get to work with, have the privilege of working with. But I think that's where it's at. It's really nicely compartmentalized. Not much is missed along the way. I'm sure.
Just to summarize, Reza, I'm going to give an example. So in the lab, we have surgically facilitated orthodontic treatment is being demonstrated. Inspire and soft tissue surgery, MARPE, so mini screw assisted rapid palatal expanders, and MSDO, which is the mandibular sagittal distraction osteogenesis. That's just a sample. There's going to be Laforts, BSSOs, bilateral sagittal splits, genioplasties. And so, a lot of orthodontists, I know personally, would never see these things in person. Like we graduate residency and we're doing orthodontic cases, but we've actually never seen a surgery. Like many of us haven't. I personally have. I've taken an interest in doing it, but I can tell you when I graduated residency, I had seen zero. And so this is a very unique opportunity to actually get into the nitty gritty of that, because it just makes you a better clinician when you see this. You know how to handle your patients better, and not everything goes as planned. So being able to see that can help you handle, I think, when things get off track. So yeah, this is, I think, a great adjunct that Dr. Movahed has recommended and kind of pioneered for this course in its evolution. So it's fantastic.
Well, and I'm going to piggyback on what, you said, Jeff Rouse said, which was, it just makes me a better clinician to see what you're doing. And I say this a lot to people who might push back at me and say, I don't want to do, I don't want to do expansion in my office. I don't want to do myofunctional therapy in my office. I don't want to work with the ENT. I don't want to do any of this. I don't, it's going to make you a better clinician to be able to walk along, especially as a primary care dentist. We see these people womb to tomb. We're walking their entire journey. And we just interviewed Una Ku last podcast, and I love it. She said it's the superpower of the primary care dentist, because we have this bird eye view of their entire life. And we are so influential in what their next decisions are because they trust us, and we might have been seeing them since they were little, and now we're seeing their kids, and which is really dating me right now. But I think for me, when I could see what it is that Maz is doing, or I know better what it is that Reza's doing, I now can explain, I can identify which patients are better candidates for that. I now can have better conversations. I can better guide them as their primary care as to risk, benefits, alternatives. I just think it's our responsibility to understand these procedures. You don't have to be the one doing the expansion and doing the surgery. But if you know what's out there and available for your patient, it makes you a better provider. It just makes you a better healthcare provider. Go ahead, Trace.
Yeah, so it's interesting because I think that what's happened probably in the last 5 years is the information is coming out really fast. And the information is coming out really fast, and many people are diving in really fast.
Oh,
And
yeah.
what that's good and bad. That's good in the sense that we're educating more, and we're trying a lot of these techniques. The bad is we don't really know a lot of the success rates in some of the procedures. And I think a lot of these procedures that Mazes and Rezes are talking about, and what we're going to highlight at Winds of Change is these procedures came out from complications of procedures. So if we think about surgically facilitated orthodontics, we're talking about changes in the bone and the tissue. So that came about when people were orthodontically expanding outside of the bone, and Reza is an amazing job talking about joints. And that discussion is happening because people still had joint problems after surgeries. So I think what's really important that we're going to find at this meeting is everyone is so humble and vulnerable about like where they are and what they learned. And I think that's going to be a really great experience to kind of be like, well, we want to, I think all of us want to do the right thing, we have to be safe, and that's what we're going to talk about a lot. So a lot of the procedures that you've just mentioned is really about being more predictable, and the biggest question is expanding the lower. What are our options? Let's be more predictable, and I love that we're having the cadaver section. I love that we're seeing DISE, because most people, I would arguably say like 95% of dentists have not seen a live DISE,
I'd say 99% of them.
99.
I haven't seen
I think that alone it's gonna be amazing. I'm obviously we're in really good company where, I'm kind of jealous that you have like everybody like literally right there and you're like walking distance. But it's going to be a really good company that weekend.
I love that perspective that you're saying. It is from trying to do better and not, and learn from our past experiences, especially when it comes to like SFOT. A lot of times, not to get too much into the weeds, but when we're doing maxillary expansion or planning for maxillary expansion with surgery, the mandible is a template. right?
Yeah.
And so if we're decompensating the mandible and I'm trying to upright the buccal segments in an adult patient, a non-growing patient, and they present with recession already, and the teeth are all tilted in, what choice did we really have historically? We would try to maybe do gum grafts, but that's not biologically augmenting the patient. It's not giving them the bone to move the teeth through. And that's been something that George has really added to our team. It's been substantial, and it's just opened our eyes up so much in terms of what we can do for the patient. So I actually just had a patient that she's committing to being one of the live patients at Winds of Change, that she was constricted. And this also goes through our decision chain. This is why these things are so important, is that my first treatment plan for her ideal was to have a 3-piece maxilla and bimax advancement. She does not want to do orthodontics, and not every patient wants to go through that journey. So then I recommended a MARPE for her in SFOT. She does not want the space between her teeth. I'm still myself learning about the diastomalist MARPE. So Robley's going to be talking on that, which is awesome. I'm so looking forward to that talk, because that's something for my journey that I want to look into more. But for at the moment, I'm getting diastomals on patients. So that's like, I have to give her consent that that's part of the process. She's like, nope, not going to do that. She's in the aesthetic business. So now we're doing SFOT on the maximum mandible to just get the arch development. And that's our third treatment plan. But we have these decision trees and these options now that are available to us that historically we would have, I'm telling you, 15 years ago, I saw this patient. If she didn't do surgery, I would have said, I can't help you.
Mm-hmm.
You know what I mean? Like, it would have just been the paternal decision that it's my way or the highway. If you're not doing surgery, go somewhere else, because I don't want the liability. And we left that patient with no options. And so this has been a beautiful journey to get to this point. And all these procedures are kind of helping us to become better diagnosticians, and also having a reasonable treatment plan. It's not going to create harm for the patient. That's the key, right? That they're going to be better off than when they started.
And you mentioned a whole portion about DISE. A lot of clinicians, a lot of oral surgeons that do MMAs, they say there's no value to it, and
Well,
it
Reza,
doesn't
can you
make
explain what
sense.
DISE is?
Oh yeah, drug-induced endoscopy. Yeah, so that's when we actually going to be doing endoscopy of the airway and see how the airway behaves in all multi-levels. Do a bit of a grading
Why do you do
system
it?
for it. Yeah, so patients are
Why do you do
sedated.
it?
Why we do it? Yeah,
Why do you
that's where we're going to get into it to learn the behavior of the airway in terms of collapsing. Okay, how is the airway collapsing? Where is it collapsing the most? And one of the things that we're doing in a unique fashion is to have different size splints that when a patient is in supine position, advance the lower jaw, which is the only jaw that you can advance, in different sizes, which would be 4, 6, 8, 10. If we can get to 10, we never want to push the jaw to a point that it's going to hurt their joints. And then see how the airway is going to behave. Is it going to collapse still? When do we get that epiglottis to really stand erect? And how is the soft palate working for us? Is it collapsing front to back? Is it collapsing in a circumferential fashion? Because it gives us more information to relate to the patient. There's chances of success and possibility of them needing other surgeries after our surgery. The more the patient knows, the better informed they are. The more trust they're going to have in you and what they're going to do post surgery. So things are not a surprise, and I think that's one of the things that we're trying to do best is to educate the patient from the pre-op portion to what's the road ahead and how things are going to be. What are the things they're going to be expecting?
Reza, tell me if I'm correct in saying this, but I thought what was fascinating from you doing DISE is that we talked about one patient where you actually went past a certain amount of advancement and the airway constricted.
Yes,
Right?
absolutely, Maz. Laws of diminishing return at times is a case because the opening that you have for the airway, if you go too far forward for some of these patients, you're not gonna get a better airway. More is not always better.
Right.
Okay, and the same exact thing comes with distraction osteogenesis for maxilla. So there are cases initially, I think MARPE has come a long way, or distraction of the maxilla, because you really just can't give it just one name. So many different tools are used to do this procedure. So there are patients that are overexpanded. The lower jaw can't match up with the upper jaw.
Yeah.
And they have Brody butts, and it doesn't look good on their faces. sorry, let's talk about that portion.
Yeah.
And if it's overexpanded patient, it doesn't mean you're getting a better airway for them. Okay, it doesn't work that way. Sometimes actually collapsibility is going to be worse because you're
Yes.
widening the airway. Okay, so that means the Bernoulli's principle. There you go.
Yes.
It's gonna actually collapse more. And not just that. If you're not doing MMA afterwards, that overexpansion is going to work not in your favor. It's going to work against you. Your sleep apnea could get worse. So these are all the series of small pearls that we have to be able to relay to our patients of the fact that more is not always better.
That is something and I've, been doing the mandibular advancement or stabilization devices for over 20 years. And we explain that to patients. Just because I advanced you a couple millimeters, I took you edge to edge and you got a little better, you can miss your sweet spot. And they just think they can go on their own, do a boil and bite. I mean, people are throwing their jaws out, wrecking their joints, making their bites irreversible. Like, you have to make sure you are seeing someone that understands, working with a dentist or somebody that understands this, because you unfortunately have a lot of bad information out there. I mean, there's even sleep physicians out there telling patients to get boil and bites, and it blows my mind. And
Yes.
they think it's more is better, and it's not. People are overexpanding. Something that was just in talking to Karen Parker Davidson, I think we're going to start just getting more and more information. Stanley Liu had mentioned this too in the past. Just a bigger volume doesn't always mean you're going to be breathing better. We've got physiology, you've got neurology, you've got aerodynamics, you've got the flow, you've got resistance. There's so much that's going into this that we're going to learn. Because if bigger was better, empty nose syndrome would be fantastic, but it's not. It's awful for patients. So when you take too much of the turbinates, which is what empty nose syndrome is, these patients kind of feel like they're not breathing, but the volume is huge. And, Karen Parker Davidson was talking about resistance. You can overexpand. Just because you can doesn't mean you should. There is a spot where the harmony is just right. Are you in sound bone? How are the jaw joints doing? Where's your tongue position? What does your face look like? How are you speaking? And how are your symptoms? So you have to have a whole team to kind of wrestle with all those things.
Reza and I are dealing with a patient right now that he's gone through MMA with us twice. Okay, we did revision on him. I'm talking about Reza. I'm not gonna say the name, obviously.
Yeah, I know.
But,
I know exactly what you're talking about.
the gentleman is a nice
Super
guy,
smart guy, super
Yeah.
smart.
very appreciative of everything. His airway is absolutely enormous. He has no problem sleeping, but he's currently complaining about his tongue still feeling like it doesn't fit in his mouth. And he had MSDO, he had a 3-piece, so we've expanded him. But he still doesn't feel like he has enough room for his tongue, so now he needs a MARPE, and we're considering advancing his maxilla again to facilitate what he's looking for. And he's coming to us with these things. It's not affecting his quality of life, other than he feels like his tongue wants to be
Low.
like laid out.
Okay.
Wants to be forward and more forward and out, and he says we have another patient from England coming in with the same concern. So from a diagnostic standpoint, you mentioned all those things, Stacy, but we don't oftentimes we don't plan surgery around tongues, and that's something that, to me, my mind now is becoming more and more of a variable that I want to understand more, because we always go we go from the face backwards, or we go from the bone backwards, but the soft tissue, obviously outside of the face, the tongue is the biggest one that is a variable that we need to also learn more about, and maybe treatment plan surgeries around or faces around at times.
Yes. And I'm actually speaking right now at Changing Minds course at Angie Tenholder's facility. Reza, you weren't on earlier when we were talking about this, but when you're coming from a neurological perspective, I mean, you've got this muscle, okay, that is driving growth. It's driving development. It is the best and the worst orthodontic, system on the planet. So if that tongue is not where it should be, it can blow your teeth out, or it can be the most beautiful retainer to hold everything in place if it's functioning. But we're also learning too that tongue posture, there's papers coming out that the position of the tongue, where the position of the tongue is, affects vagal tone. It affects how your sympathetic and your parasympathetic are switching on and off. So, we used to say tongue should be completely full in the roof of the mouth. Well, maybe just the tip of the tongue now. You got to be able to go low with the tongue, and you got to be able to go high. There's so much we're learning about the tongue and its influence on vagal tone and neurotransmitters and just our overall wellness, that I think is going to be interesting what you're saying, Maz. We're looking at all the hard structure, and we look at function when it's kind of in the way, like myofunctional therapy. But what if, this giant muscle that is, we're building everything around it and we don't really talk about it much,
Yeah. So I think we keep talking about this new journeys we keep going on and what we're learning. I feel like that's probably the next thing for me to understand more about, is exactly how to diagnose treatment around the tongue. Just because I'm seeing patients, I mentioned the two. I have another lady that came in that had a tongue tie release, and she says it's ruined her life. And like she feels like now she went backwards from having to release, and she wishes she never did it. And I'm just wondering what the cascade has been for her, and trying to dive into that more. And now we're considering doing a marking on her to give her more room for her tongue, because she has the same issue where her tongue spills out over her occlusion on the mandible. And so it's just there's a lot to get into. There's a lot of information, as you said, but there's a lot to learn still. So I still feel like I have a lot to go through on this journey, to be
It's
honest.
funny. Yesterday, no, I'm sorry. We got 4 people on here and we're all excited. I mean, I had a guy yesterday at the course walk up to me and he said, because I was talking about restless leg, and one of my passions is the non-anatomical aspects of sleep and wellness, and he goes, well, I really appreciate your lecture, but I just feel like I'm walking out more, I'm dumber than ever, because I just don't feel like I know enough about anything. I said, how do you think I feel? I mean, it's just like the more you know, the more you realize you have so much to learn, And but that's where the humility, and I love this about Winds of Change, is everyone coming to the table. This is what I know. What do you know? What can I learn from you to make me better? How do we learn from each other to help more people? And with the humility that we don't have all the answers. We know we have a lot more to learn, but wow, where we're at right now is light years from where we were at a decade ago.
Oh man, yeah. I mean, our patients are so smart. That's another part.
Yeah.
It has made our jobs so much harder. My surgical consultations like we were just talking about post-op more than anything else. What's going to happen? What are we doing? Now we're talking about the general mechanics of what we're doing. How much we're counterclockwise rotating? What we're doing with expansion? I really feel like, as Dr. Moshiri would tell you, we have a patient right now who is probably smarter than most, orthodontists and oral surgeons in terms of his knowledge, and we feel that we're inadequate in certain ways to respond to him because this guy has read everything, and it's not just reading what's online and opinions. They go and read the papers.
Yeah.
So you better have your A game on to be able to, have that conversation with these patients, because, yeah.
You're right. And that's a good point.
And people are consuming it.
You really, if anything, we are having patients with social media, the good and the bad that come with it, right? But we have patients that are more educated. They have so much more data flowing at them, and they're trying to put all the pieces together and come up with true information to make decisions from the data, because it's all over the place, which is it's great because they have access to it. But I feel for patients today. You go back 50 years ago, and, I just remember how my mom and dad used to talk about when they went to the doctor. They never asked questions. They walked in, the doctor told them what was going to happen. Okay. And then they would leave, and I would be like, well, what did they say? Well, our generation didn't ask a lot of questions, right? Well, that's gone. But you, as a healthcare provider, you really got it. Like you said, Reza, bring your A game. You got to really know, you have to, as a provider, now be able to quarterback all this information for your patients. Sometimes, yeah, they walk in and I'm like, yeah, I'll have to read that paper myself. Where did you get it?
Yeah.
And
And yeah, so one of the surgeons who we're going to have speak, Dr. Chantis Klaus, he's the keynote speaker for our meeting, and he's going to talk about MIOS, minimal invasive orthodontic surgery. Well, a lot of our movements are much larger and probably doesn't go in the category of MIOS, but there's so much I can learn from him that I can add. And I'm sure our patients are going to be all over the idea of MIOS. So I'm going to get ahead of the game and I'm going to learn about that at this meeting from him.
wow.
I'm exactly, and I think that's super important. And when it comes to arthroscopy, I do basic arthroscopy in office. The future biggest name for arthroscopy is going to be with us and speaking, Dr. David On. So he has many residencies. So I want to learn more about the conservative side of taking care of the joints with arthroscopy and how far we can take that. The first day is going to equip me orthodontically. I'm going to be paying attention to every second of that because as an oral surgeon, I'm getting those questions, not just as an oral surgeon, I'm getting those questions from the patients in terms of the expansion. So I want to know what this FME device is going to do.
Yeah, Maz, what's going on with all the ortho? You said you have a very diverse platform for orthodontics and expansion techniques.
Yeah, so in terms of the speakers that we have going on there, it's kind of starting with, I would say Dr. Ferrari is going to give just a global perspective on how she sees an airway patient from, as you said, womb to tomb, right? In terms of just seeing that patient holistically, because obviously as orthos, we see that spectrum as well of patients. Dr. Kim is going to be talking on mandibular distraction, some visual distraction osteogenesis, which I think is a procedure that has fallen out of favor to some extent, but I think it's because we didn't know enough about it and how to do it properly. So he's kind of bringing that back into light again. Again, we mentioned the mandible is the template for the maxilla, and oftentimes patients need more mandibular width or volume to really get the airway impact we're looking for. Dr. Robley, who I'm personally, Reza is looking forward to some people speaking. I'm really looking forward to him speaking as well. He's doing a lot of these surgically facilitated orthodontic treatments in conjunction with aligners, and also doing it in conjunction with MARPI, with mandibular, with Moshiri assisted rapid palatal expanders, and getting those diastemalous expansions. So he's kind of approaching it from both regards there. So different ways to kind of skin the transverse on the maxilla, if you will, but just going through the techniques that are probably a little bit more patient friendly, because again, I think one of the things that holds people back is that huge gap between their front teeth. So there's a way to do that is more aesthetic, and you're still getting the same airway benefit. I think that's going to be really huge. And I'm speaking myself on just kind of how Reza and I plan faces and how we set the cases up to maximize movements for any type of orthodontics that we do in terms of decompensation specifically, so putting the teeth back where they should be, how we incorporate, again, adjunct procedures as well in order to do that. So just going through a lot of different variables and angles on mainly the transverse, but really just how to also then see patients from, again, womb to tomb as well, and how to make the corresponding maybe recommendations or age-appropriate recommendations to help them out.
And Moz, we're forgetting about the fact that we also have two radiologists. We have two maxillofacial radiologists that specifically, one is going to talk about hard tissue and one is going to talk about soft tissue. Not many dentists know about MRI and the value of MRI.
Right.
Okay? That
Because most people don't know how to order an MRI.
Yes.
Yeah.
So it's not even like about reading it, it's even how to order.
How do you order one? Right.
Yeah.
I mean, we understand this displacement. We understand anterior displacement without reduction. These are the things that we understand. Once you look and sit down and go through 10 or so of these MRIs, all that you know is going to come to light. Then you know the value of ordering it. Especially, I do my best at St. Louis University to teach the residents to read MRIs. Most of the time, they're not paying attention because everyone's just trying to get out of the residency.
They're just trying to get out.
I want to go to work and make money, but but if you see a patient that has the anterior open wide, please get the MRI. At least do your due diligence to look at the scan and such, and know how to read it, because 50 to 60% of the MRIs are not properly read. But so it is up to the dentist, orthodontist, oral surgeon to read that. And if there's a mistake, communicate with the radiologist. And hey, I'm seeing this here. Seems like a copy and pasted for the right and left. Obviously, not much thought has been put into it. Classify it for me, or put the right dictation in there, because that could change the course of what they're going to be doing in the future, and also knowing if there's a chance for relapse. And that is, I would love for Maz to talk about that, because relapse happens in orthodontic offices due to many reasons. And one of the foundations is the joint. So Maz, if you want to kind of elaborate on that, this is a good portion of the data that we're going to get, but please.
Yeah, I mean, Reza and I, unfortunately, are retreating a lot of patients that have had previous orthodontic surgery, and it's just from not looking at the joint, I think, carefully enough prior to surgery. If the patient did have any dysfunction, especially the patients that are more prone to this are high angle class 2 females that on advancement really have a higher incidence of relapse. So we obviously, all of our patients, we give them informed consent. If we see that there's any type of internal joint derangement that is flagging us that the degree of advancement may put pressure on that joint for relapse, we recommend joint replacement. Not every patient goes through it, but again, they've been informed about it, because you don't want to be in the end where you didn't say anything and then they go through that relapse after going through a major procedure, and then you're having to do it all over again. So there's systematic reviews now that kind of go through the literature, but the incidence is anywhere from, I think, 1 to 30%, Reza, in terms of actual condylar absorption after orthodontic surgery. So it is documented in the literature, and something to definitely be aware of when we're talking about bringing faces forward. For every action, equal opposite reaction. Soft tissue is pushing back. If it's pushing back on a joint that has any duress going into surgery, there's probably a higher incidence of relapse happening of that surgery overall.
Trace, what are you talking about?
Oh, I'm just going to talk about like the journey, the journey and finding care and what we're looking at. I think it's really, what I said earlier about like how this information is coming out so fast, and I think even these techniques are coming out really fast. And so I think what will be really interesting is for us to do comparison in of these techniques from an airway standpoint, not from like, because we're trying to go beyond the orthodontic standpoint. Obviously, so all these new expansion techniques, while they're great, like, is it a different impact to the airway? And so I think it'll be really interesting to see with all these new techniques. I think another thing too is what people don't understand, and this is to go back, we talked about DISE, which is drug-induced sleep endoscopy. What my readers and dentists probably don't know is when I was doing this with my ENTs, I thought only my sleep physicians could do it. And it wasn't until probably the last 3 years did my oral surgeons that I know that oral surgeons can do it. And, this is great for Reza, because I'd probably say only a handful of oral surgeons actually have it that are in their practice. The beauty of that is access to care now. Like you basically, patients, all ages, I mean, because we actually, we do it actually drug-induced sleep endoscopy on a lot of our kids. And we do it for the same reason that, Reza's doing it for adults, we're also doing it for our kids. And we're trying to make it a standard in my area that before a child gets put on a CPAP, we want to do a drug-induced sleep endoscopy, because we want to figure out, is there an anatomical compromise that can be addressed before these children go on CPAP. So, I mean, just for the parents and the listeners here, I think this diagnostic tool is very valuable in the sense that now we can be a lot more predictable in what we do. I think from an adult standpoint, I mean, if we go by the literature, it's like everyone needs to be X amount, because based on like that's the literature, what they did. I mean, it's kind of like going, Stacy, how the literature says that you have to be with the oral appliances 70%, 75% protrusion. That was always the number. But what people don't realize is they've never tested other numbers. But it became the standard of your standard protrusion because of a couple studies. And so what we're saying now with all these new diagnostic tools is like, there really is no standard starting point. We really need better diagnostic tools to make precision decisions for the patient. So I'm really excited for just even looking at some of those diagnostic tools to help us be better treatment planners.
Well,
Well,
going to be looking forward to your talk because you're an amazing speaker,
is.
truly. Both of you are. Yeah, and you know, last year wins. This is going to be so a continuation of Winds of Change from last year, and the new data that you're going to be adding because knowing in the and the part of what you mentioned, uh, in a GP office, for example, what do you have to know to be able to make the right referrals? Okay,
Right.
how can you prepare the patient? Because if the patient, you said it, that Stacy, you mentioned the fact that your patients trust you more than anything else, and they'll listen to you. So if you prep the patient for the right procedure, by the time they're going to go and see Maz is going to repeat that. Then they're going to see me, for example, and by the time they come to my office, now they've heard it 3 times. When people that have
Yes.
seen the procedures take place and with success, now that patient is going to feel a whole lot more comfortable. And we can, as David Carter says that actually, for us to speak the same language but a much more unison voice is important, even though he's not a fan of surgery at all. I know Dave personally, and that's not really an
Yeah.
area. If in his book, Empowered Sleep Apnea, it's the negatives of surgery, but that message to me is an important message. Uh,
Yes.
yeah, so for us to collaborate in a echo fashion of the right information.
Well, and
Uh,
I've had quite a few patients I refer to you to as a team, and that's how I refer to us, the three of us. I'll say, they're on the team with me. You've got to see him first. We're going to address jaw joints and surgery. We got to do orthodontics and expansion. This is the team. This is the only team I want you on. Like, don't go. I'm like, trust me. So but I get tickled because, they'll tag you guys on Facebook and just, they'll show their kid or they'll show their loved one. And then I get tagged in there and I'm like, it feels so good. I didn't do anything, but
well,
it
you
feels
did a
good
lot.
because I feel like
Brought everybody together.
it brought everyone together. I feel like that is a very influential. I think sometimes just vulnerably speaking here, like I'll get imposter syndrome or I'm like, what am I even like, what am I doing? So
You're
like,
the Bill Belichick of the whole game. Let's put it
I
that
think,
way.
you're underscoring like the importance of like the emotional support.
yes,
I always say
yes,
like if anyone's going to go through orthodontics, like there's somebody has to be there for that emotional
it
support.
does. They have to really understand and be very, they just have to, it's just our responsibility to let them know this is everything you're going to experience. And, they talk to other patients that you guys have had, gone through therapy with before and treatments with before. And so they have the support from prior patients that you guys have treated. But I think I definitely get a warm and fuzzy. I'll just say I get a warm and fuzzy when they include me on the tag and they include me on the team. And I just think it's so important. I keep saying it for those of you that aren't wanting to do the procedures, I cannot emphasize enough the importance of understanding what your colleagues are doing in your community because you could just, if I could even tell one of their stories, I mean, I couldn't get through it without crying because this isn't just like you are affecting their whole quality of life. There's a lot of decisions that come from, especially, whether it's addictions or poor choices in their life, when they're going through chronic pain, poor sleep, these patients are suffering, they're struggling. And the reality is, the medical community does not have answers for them beyond CPAP or, Inspire. That's it. So, what I love about being in the dental profession right now is we're starting to see that I really feel this medical dental collaboration is going to blow up. We really we have a seat at the table and we can really change the lives. I mean, I know personally, Maz and Reza, you guys have changed the lives of quite a few of my patients. And these parents privately text me like they'll be in recovery with Reza after Reza's surgery, and our girl's doing good. I'm like, of course she is. And, I'm cheering them on from behind, and look at her face. And Maz is fixing a lot of, well-intentioned poor orthodontics in the past for a lot of my patients, and, giving them room for their tongue and improving their face. I mean, I could tell stories, but I just think I can't emphasize enough that I just am excited about what you guys are doing with Winds of Change. I'm so proud of you both. I know it's hard work putting these symposiums together, in ASAP, just even putting a couple our courses together. It's a lot of work behind the scenes, and what you guys are doing is large scale amazing. So thank you for all your hard
We really
work.
couldn't do it without our team, Sarah and Pat, and they've all put in
Oh,
so much.
heck yes.
Stacy has been putting so much time into it. Maz has been putting so much time into it. Dr. Mandelaris, but I got to tell you, I really couldn't do a lot of what I do without the other bald man and this, fourth screen that we have going on. It's a privilege working with him, and I just want to sing his praises because when I'm working with Maz, I know things are going to be okay. We've done upwards of over 250 cases together right now. And Maz really has changed the face of orthodontics in every way possible, and through Invisalign. And when he first started his course, it was just really for orthodontists to do the basic in-office stuff. And then he dug into the ortho surgery realm of things and came up with ideas and ways to make this predictable. We started doing our segmental cases with Invisalign. We figured out that part of it and how to do it. And every bit we're taking another step to perfect it more and more. But he's like a orthodontic ninja in every way possible.
Yeah.
And cases go in, and just this beautiful smile shows up when they're debonded. And in the meetings that I speak at, everyone says like, "Who did your orthodontics?" In that case, it was like Moshiri, Moshiri, so on and so forth. So yeah, we all help each other get there, but we're all performing at a high level, and that's what our patients expect of us to do. But one more thing that I want to put out there to tell you that it was really amazing. I'm right now, we're in California office, Bay Area, and we had two patients. Okay, one patient was about 4 months ago. We did surgery on. She needed prosthetic joints, and she was very scared and suicidal. Ideations were there, and she mentioned if within 3 years things are not going to work out for me, I don't have the will to live, really. And this is with the whole family around her and such. And she showed up this past week, different person, pain's gone away, all the rest. I mean, it gives reason for us to be. But it also, on the other hand, I had to have a patient that airway is so small, I'm telling you, it is the soft palate is right against the pharyngeal wall. There's no space, 0.6 millimeter minimal cross-sectional area. Okay, and she's been dealing with a whole host of problems all along, and she is so fight and flight mode, and also depressed as well, that she has a hard time even going through the next step. So that then goes to the psychological aspect of it that we have to include in too.
Right.
But what you mentioned as dentists, as in a profession of dentistry, has given me so much. And now the seat at the table for us is huge. It's a great time to be a dental professional because the digital world of it, the airway portion that's come into it, it is truly a revolution in dentistry. So I think we have a major seat on the table, and I'm so glad to see our colleagues taking this seriously and taking us to the new generation of us doing the surgery and doing what we do in our offices.
Well, we're getting close to the end of time, and I think we could talk for 4 or 5 more hours. But I wanted to let's talk about it's in Chicago this coming year, February 5th through the 7th. People can register at windsofchange.net. There's a nice little register button right there.
Actually, it is windsofchangeconference.net.
Oh, wait, hold on, because what I got pulled up does not say that. So I'm going to, let me look at it. Yep, windsofchangeconference.net. So sorry, that was me.
All good.
Thank you, Sarah, in the background for correcting that. So please go and register. I'd love to see everybody there. We actually last year, Winds of Change, I had a few people reach out that said, "Hey, I heard about it on the podcast. That's why I went. Thanks for bringing it up." So I'm hoping we get more listeners that really want to see what this is all about. And then I want to do real quick ASAP business. It's Thanksgiving. We've got a Black Friday special. Trace, did you want to talk about it really quick?
Oh yeah. So if right now what we're doing is with comprehensive membership, we actually did a whole we're doing a whole mini residency next year. So there's four courses. The first one is the basics of dental sleep medicine. The second was early orthodontic intervention. The third one is adult intervention strategies, and then the last one is business. So now with the Black Fridays, you get 35% off that whole curriculum, or you can just join us on our first course, which is going to be in my hometown with just the basics, the basic understandings, the introduction to dental sleep medicine. And I think what we do really well in we are not, we're not an orthodontic program. We are a program that really tries to hone in on everything with dental sleep medicine with children and adults. So our focus is really trying to understand this disease, understanding who you need in your team. And that's why I feel like ASAP has been really good about. But yeah, we definitely feel like anatomy is one piece of the puzzle, not
Yeah.
the entire puzzle.
Not the entire puzzle,
Yep.
100%. We're learning that more and more every day. So I'll put all the links to register for Winds of Change. We'll have our Black Friday special. If you want to become a member of ASAP, we'd love to have you. We have our immersion, and we have our the practice breakfast club too once a month, which is a lot of fun. But before we go, I've got my 3 random questions. And since it's Thanksgiving, here we go.
Let's do it.
First question. And I mean, I don't know. Is everybody going to do something for Thanksgiving this year? Before I stick my foot in my mouth and ask you Thanksgiving questions, I've done this before and I have gotten myself in a pickle. Are you guys celebrating Thanksgiving this year?
Absolutely.
Okay, Maz?
Yeah.
Okay, so here we go. Because I don't know, not everybody does.
Well, I don't like turkey, but I
Well,
celebrate
okay,
Thanksgiving.
you're ruining my
Religious
question.
holiday.
Okay, so question 1, and I'll go around. If you eat turkey, are you dark meat or white meat? And if you don't eat turkey, what do you eat instead? Go ahead, Maz.
I'm a white meat guy. I like white meat, but it just gets tricky because sometimes it can be too dry. So
Yes, got to be good.
yeah, have a good white meat, but I'm a white meat guy.
Reza?
Same. White meat.
I'm white meat too. Tracy, what
No,
are
I'm dark meat.
you? You like
I mean,
real
the closer to the
greasy?
bone, the juicier it is.
She like
I'm
sucks the
Asian.
meat off the bone.
And then on
Wow.
top of that, I'm not a huge turkey fan, so like I need Asian dishes. So I'm all about like barbecue pork or duck and things like
You
that.
do duck, but I'll tell you what, she brought a plate of duck out. She always introduces me to new foods. I'm like over there I'm pulling the, meat off the bone. I mean, Tracy gets primal when she
Good
eats
stuff.
and she's
stuff.
like sucking the bone and I'm like, she's got bones flying. I'm like, you want a napkin?
I joke around. I'm like, yeah, I'm from a third world country. We put nothing to waste. Like I eat everything. Do I look
She
like
does.
to be on a restricted diet? No.
Oh my gosh. Okay, number 2. All right, I'm going to go back to you, Maz. What's your favorite dessert at Thanksgiving?
I'm a tried and true pumpkin pie guy. I love a good pumpkin pie.
Oh,
That's my favorite.
okay. Reza?
Apple pie, vanilla ice cream.
Ooh, a
Come
warm
on.
apple pie a la mode.
If rhubarb would have been available, it would have been rhubarb pie, but apple pie, vanilla
Apple
ice cream.
pie. Trace?
Big dessert person. Anything chocolate is good for me.
Chocolate is good. You
Just
can't
not
go
a big
wrong with
dessert. Yeah.
chocolate. I'm a
I
yeah.
like the Thanksgiving meals.
I know you don't. I mean, which is why I'm like, some people don't like. Some people are like we just do brisket or lasagna. I mean, some people don't. I like pecan for the record with a cup of coffee. That's my favorite. And then final question.
Listen real quick. I went to school in Louisville, Kentucky.
Oh, ho, ho.
So are you familiar with Derby pie?
No, well, no, I
It's
am
Derby
familiar.
pie.
I haven't had it, but my aunt lived in, I think it's Mayfield, Kentucky or
Uh,
something. And she talked
so,
about Derby pie. What is that?
so Derby pie is a pecan pie with chocolate chips.
Oh
It's so good. It is
my
That
so
gosh.
good.
that does sound good,
I
It
actually.
highly recommend.
sounds so good. I actually am doing a cheat pecan pie this weekend. I'm doing an early family Thanksgiving. And it's this basically a mason jar full of all the pecan, like molasses and pecans and everything. Apparently, it's one of the best cheat pecan. And you just add butter and flour, and I'm excited to make it. But now I'm like, why not throw some chocolate chips in there? That
That's
sounds
right.
good.
It's so good.
Oh yeah.
Okay, final question, a little deeper, but we'll try to keep it brief. What are you thankful for, Maz?
I'm truly thankful for my family. I have two beautiful kids, 9 and 11. They're both at wonderful ages right now. I'm really enjoying where they're at, watching them grow up, and they're, thank God, healthy and doing well. Mom and dad still alive too, so just
Mm,
thankful for where I'm at in my life, my family, and trying to soak it all in because nothing is promised or forever. So
that's
definitely
right.
grateful for the current circumstances.
Well said.
Thanks.
All right.
Yeah, likewise for me, thankful for people I have around me that support me to be able to do what I love to do. My significant other, Sarah, and the fact that able to help these patients get through their hard times and give me more of a purpose of being here and
Yes.
continue to do this. That really is something I'm every day waking up. I'm thankful about because as always said, love what you do, never work a day in your life. Could not be any more true. It's not like going to work. So
Mm.
I'm
Well, some
along
of
for the
these
ride.
patients, they become an extension of your family. They become an extension of, your purpose and your calling. And that's a very
Yeah.
special soul level thing.
Uh,
Yeah, I don't think people realize that the speaker life is not that exciting. But like this, but the beauty of what we do is we can impact more.
Mm,
And like so, but probably before I started this journey, the only people that I could impact was my family and my patients. But now if you educate more dentists, your reach is stronger. The amount of people that you treat are stronger through other people. So
Tracy, what are you thankful for?
I guess that the ability to, I mean, the ability to do that now and then just life in general. I think we just take advantage of all the little things that we're able to, I mean, even the ability to walk and think. So it's
Mm.
just,
oh,
I'm like just happy about
faithfulness.
that. Mhm.
Well, you were thankful last night when you texted me, I'm finally home, and you were
I know.
snuggling with your dogs, and I said, "There you go, Winston and Harry. I know you're
I'm telling
thankful."
you, like, if you don't get it, it's funny because people in my office, even my team, it's like the speaker life is not exciting. I was traveling every weekend, but I look at it as like the more I reach, then they have a different thought process and their whys become different too. And I think dentistry is a beautiful time right now because we're going
Yeah.
beyond the facial aesthetics. We're actually now looking into being the health aspect of it. And one of the things when I speak, I say, all I ask is just don't make it worse. All I ask is to understand how to not make it worse, and let's
Please,
just
please
let's
don't
just
make it worse. Yeah,
together. Yeah.
yeah, that's very good point. Well, I'm thankful for, you guys today and taking the time. But I mean, my faith, my family, my friends, the journey, the older I get, I do see less and less. I don't believe in coincidences, and I feel like people are on my path for a reason. That could even be the grouchiest patient at 8 a.m. on a Monday. And I'm like, why is this person on my path? And I try really hard to, what am I supposed to learn from them today? Maybe they're teaching me something today about myself. So I'm just trying to be more mindful. I'm thankful for grace of that people extend to me and patience. And I just think I'm thankful for life in general. So just trying to be more mindful of that. Well, I appreciate you guys. Thankful for you today. And we're going to have all these links in the podcast. We're Gonna join you again someday soon. These two superpowers that we have on the podcast, I love having them and I learn from them. And I'm so lucky to have them in my town. But I'm thankful for you, the listener. And don't underestimate your importance for taking the time to listen today and the changes you're going to make from the knowledge you gain. And so thank you to you as well. I'll see everybody. Bye.
Bye.
See you next time. This podcast would not be possible without the inspiration of my dad, Daniel Becker, and creative direction and editing from the very talented Jason and Dane Becker, Ben, Lydia, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And please remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice or to replace your healthcare provider's diagnosis or recommendations.